There we go. Okay. So during our discussion today, please feel free to use the raise hand feature or the chat box to ask questions or comment. I anticipate that a few others will be joining us, but if our group remains a pretty small group, I think raising your hand is great. I think that's a good way to manage comments and questions. So let's see. I also will have a brief poll that I'll launch when we have about 10 minutes remaining in the session. So I'll send you a heads up via the chat when the poll's coming. It's 3 or 4 questions. It just gives an opportunity for you to give us some feedback on this event and kind of helps us shape future programming. So with that, let's start with just a short round of intros of who is in the room, so we can get to know each other just a bit and begin to create space for our conversation today. So since we do have a smaller number, I think it'd be great if we could do verbal intros. I love that. So what I'll do is just hop around the room in order of who is on my screen. So Jacqueline, you're at the top. I'll start with you, if you don't mind.
Sure. Thank you, Laura, and thank you for having me here today. My name's Jacqueline Summers. I'm the managing director of a program based in Alaska called Health Tie. We are an Alaskan healthcare innovation hub that's a bridge between healthcare innovators and the Alaskan healthcare system. And we both introduce new ideas and we also project manage pilot projects. So excited to be here today and happy to make any connections if anybody wants to follow up. Thank you, Laura.
Wonderful. Thank you. Rebecca, you're next.
Great. Thanks, Laura. My name is Rebecca. I am the Community Relations Manager at the Fred Hutchinson Cancer Research Center here in Seattle. Excited to hear from folks today.
Great to have you with us. Jesse.
Yeah. Hi, I'm also based up in Seattle, but work for an early stage startup that's really building virtual primary care for people of color, as well as building cultural competency training for people kind of in and around the healthcare sector. I'm kind of in charge of our partnerships and happy to be here and be a part of the conversation.
Great to have you with us. Gail.
Hi, yes, I'm Gail Shank. I'm a health standards and interoperability lead for MITRE Corporation. MITRE is a nonprofit out there trying to do things in the public's best interest. And I'm very interested in the social determinants of health and that data and how it's collected and how it eventually will be standardized for reuse and all the great research purposes and patient impact care that will be available.
Thank you, Gail. Love to have another interoperability person in the room. I love interoperability. That's great. Melina.
Hi, I am a family nurse practitioner, currently working with the CDC to improve vaccine confidence, but I am also a doctorate student and focusing my doctorate project on health equity.
Great, thanks. Glad to have you with us. Amy.
Yes, I'm a business implementation manager at Primera Blue Cross, and I'm with the quality program, and we're doing a lot of work now with health equity as part of NCQA accreditations.
Great.
And I may go off the camera because my system sometimes boots me off when I have the camera on, so.
That's totally fine. Yes, I understand the bandwidth challenges that come with virtual meetings for sure. Let's see, Shelby.
Hi, everyone. I'm Shelby Stovall, and I work for Alara Caring. We're one of the large nationwide providers of home health and hospice services, and we're focusing on value-based care as well, partnering with Medicare and commercial health plans. And I'm normally located in Seattle. Today I'm in Dallas and I'm on my way to the airport. So I'm going to be off camera as well, but listening in. Thanks.
Great. Thank you, Shelby, for joining us. And I see you're enjoying sunshine. I'm a little bit jealous. It is quite cloudy here. Malia, I think, was changing devices. I'm not sure if you are able to introduce yourself or not yet. Let's see. Maybe not yet. Okay, that's great. Well, thanks everyone. All right. Oh, what a good group. I'm so excited. There's some new faces in here. There's some familiar faces in here. I think this is going to be a really great discussion. So here at Cambia Grove, we serve as a catalyst to transform healthcare towards a more person-focused and economically sustainable system. We do this through collaboration with the 5 points of healthcare: the patients, payers, providers, policymakers, and purchasers, as well as with other aligned stakeholders and innovators across the healthcare system. As healthcare innovators, we all must work together to reset the playing field, to create a focused relationship between innovation, outcomes, and the ecosystem elements that are necessary to support impact. A couple of years ago, Cambia Grove developed the Healthcare Innovation Advancement Framework. We believe that innovation should fail because it's a bad idea, not because the healthcare system isn't set up to adopt it. So our goal is to drive transformation by optimizing 3 key elements of the healthcare ecosystem. And these are infrastructure, incentives, and culture. So the infrastructure would be resources that are needed to support development of solutions, as well as the appropriate physical and technical systems like interoperability, Gail, and broadband access. Those are just kind of 2 components of that. Incentives are those elements that are key to driving behavior. So we mostly find these in the way that our healthcare system pays for care. For example, is it through a fee-for-service model or value-based care model as one example of these incentives? And then finally, culture, arguably one of the most important. Culture focuses on trust, openness to change, and having the cultural competency to create solutions that match the problems that exist. I think too often in the healthcare innovation space, we find ourselves with solutions that are looking for problems rather than looking or identifying problems and then creating solutions that address those very real needs. So the theory behind this innovation advancement framework is that by optimizing these 3 elements, impactful innovation can more seamlessly lead to impact of the triple aim. So our discussion today will help us in our collective efforts to optimize a culture of healthcare transformation. We'll link to the framework at the end of today's conversation and in that follow-up email for your reference if you'd like to take a deeper dive into that. I think, core to any conversation about healthcare transformation is this topic of diversity, equity, and inclusion. We want to ensure that diverse voices and perspectives are represented and heard, and we need to be equipped to understand how we can do better while developing actionable next steps. So with that, we recognize that we're imperfect in our pursuit, and we know that growth and learning can only occur as a result of being willing to be uncomfortable. So to create that space for ourselves and these important conversations, we invite you to be bold with your vulnerability here in this discussion today and share your authentic self. Ask the questions that you're wondering about, listen to learn, and maintain an open mind. With that, if you say or hear something that could be handled differently, please respectfully identify that moment as a learning opportunity for the group. You could do this, by using the chat feature, raise hand feature, the direct message feature. All of those would be appropriate methods. So as we begin today's discussion, I think it's fitting to start by acknowledging that the land where the Cambia Grove team sits in the Seattle region, we acknowledge that we gather for this event on the traditional land of the Duwamish, Muckleshoot, and Coast Salish peoples, both past and present. And we honor with gratitude the land itself and the people who have stewarded it through the generations. If you would like to learn more about the native land where you live, I will paste 2 resources in our chat and share them in our email as well. It's a really great way to see which nations occupy the land where you live. I think it's a really great, both of these are really great resources for that. So now it is my great pleasure to introduce Mardia Shantz, the Chief Diversity, Equity, and Inclusion Officer at Swedish. She has extensive experience in social impact, diversity, equity, and inclusion, and workforce development across multiple industries, not just healthcare, including manufacturing, supply chain, and IT. And so I'm excited to kind of hear how Your story is woven through these industries and about healthcare, like we were talking about before we started. So welcome today.
Thank you so much, Laura. How kind and gracious of you to invite me to this roundtable. Everyone, thank you so much for coming out and giving us this opportunity to talk about diversity, equity, and inclusion, health equity, and having a chance to just have some dialogue around this critical topic in the space that we find ourselves today. I am truly thrilled, privileged, and honored to be here with you today, and I'm looking forward to a robust conversation. And so I ask that you be transparent, as will I, and will share information with you to the best of my ability. And I'm one of those people who, if I don't know something, I will tell you I don't know that.
That is great.
we will talk about it and get to the heart of the matter. So thank you again for being here.
Yeah, of course. Marty, do you mind, as we're starting our discussion and just kind of to level set and make sure we're operating under a similar understanding, would you share us kind of what diversity, equity, and inclusion mean, particularly in the context of this discussion today?
Sure, absolutely. So one of the things that I like to do is start with definitions, and I call them operational definitions, so that we, again, to level set, where are we and what is it that we're talking about. And so when we talk about diversity and equity and inclusion, diversity represents everything that is similar and different about us. And when in particular, when we talk about diversity, the dimensions of diversities come into play. And there are a wide variety of dimensions of diversity. And mostly, though, people think about race, ethnicity, and gender, and sexual orientation, and gender identity, and so forth. However, diversity spans what exactly could be your profession. It can be, what is your familial status? Are you a single parent? Are you married? It can be about your socioeconomic status. It can be whether or not you are a single child. Are you a middle child, as am I? It could be neurodiversity. It can be physical diversity. And it can, again, all of those things that make us who we are, our individual selves, our lived experiences, all of those encapsulate who we are as individuals and what it is that we bring to the table, our diversity of thought, again, our lived experience, everything from who were our parents, what did they teach us, what were important to us, what is our cultural heritage, and so forth. So all of those things that make us the individuals that we are represent the diversity that we bring into any space in which we enter. And so when we talk about diversity, that is, in essence, those various dimensions of diversity that I like to focus on, and not necessarily just, again, those that you tend to see when people mention the word diversity with regard to race and so forth. And then from the perspective of equity for me is providing to people what it is that they need in order for them to be successful. And oftentimes we tend to use the word equality and equity simultaneously. However, most of us are aware that equality says, well, let me give everybody the exact same thing. And equity says, well, no, let me give you what it is that you in particular as an individual need. And and I'm going to talk specifically about the United States, because this is the space in which we are in. And so in the United States, what we will say is we know that people come, again, from a variety of different backgrounds and life experiences and so forth. And there is a starting line, so to speak, for many of us. And a lot of people aren't necessarily starting at the same place at the starting line. And so when we look at equality, and if we give everybody the exact same thing, and some people are not even at the starting line, we're never going to achieve equality if we give people the exact same thing. we need to create equity and give people what they need in order to bring everybody to the starting line, in order for people to compete fairly and in a manner that can give them a chance to be successful. And then even during the race, so to speak, of life, if we look at equity, some people still need to be provided additional assistance in order to be successful. And then when we look at inclusion is not necessarily, I like this quote from Dennis Day, and he says, inclusion is not necessarily looking at creating space at the table, is actually expanding space and allowing people to bring themselves and so to the table, and allowing them to create additional space at the table, and in some cases building the table out so that people can bring themselves, their whole selves to the table. And so inclusion allows people to bring their voice, allows people to show up and be their entire selves. And so when we talk about DEI and diversity, equity, and inclusion, those are the definitions that I'd like to start as a foundation before we move into the conversation.
I love that. Thank you so much for giving those examples and definitions. I think that will really kind of help frame our conversation, and the distinction between equity and equality. I think that's important too. So what I don't want to do is monopolize the conversation. I know you all have questions that you would like to ask, but I would like to ask just one more thing of you, Mardia, before we dive in. I'd love for you to kind of share a bit about your role at Swedish, what that is, what Swedish is aiming to do. I think especially given that you're the first, right? Yeah. You're the first chief DEI officer at Swedish. So I'd love to kind of hear about that and that work.
Absolutely. I serve as the inaugural Chief Diversity, Equity, and Inclusion Officer for Swedish, a role that I am extremely proud of. My organization for not only creating, but also supporting both financially, because it's important to put dollars behind this work, as well as organizationally. And I work in partnership with a chief health equity officer. So we work in a relationship. She is a pediatrician by training. And so we work in a partnership, and we have formed the Office of Health Equity, Diversity, and Inclusion. And it is one of the few models in the United States in a large healthcare system that actually has Chief Health Equity Officer and Chief Diversity, Equity, and Inclusion Officer working together to ultimately achieve health equity for every patient that comes into our organization. And so what I do, the way our work is fashioned is I do a lot of work with caregivers, employee-facing, culture building work within our organization, because we believe.
Oh no, I think I accidentally did that. I was trying to admit someone and my mouse moved. Okay. I'm so sorry.
Oh, that's quite all right. That's quite all right. So the way we have our work parceled out is I work again with internally within our organization to build a culture of inclusion, to build a diverse workforce, and to ensure that we have equitable practices in the organization. The idea being that if we can have a team of employees, caregiver physicians, nurses, advanced practice care folks who understand the principles and the tenets of diversity, equity, and inclusion, meaning people who are culturally competent, who represent our patient population, people who understand the different lived experiences of our patients, people who are culturally sensitive and empathetic, people who understand there are language barriers for patients that come into our healthcare system, people who are astute in understanding health disparities that exist because of things like structural or institutional racism, and are aware and are working to combat those things. Ultimately, it leads to our ability to combat and mitigate health disparities and to ensure that we are delivering equitable health care. And so as I do that work on with our caregiver and in ensuring that they have that cultural competence and are able to treat our patients in that manner, my partner on the other hand, Dr. Onyanku, what she does, she then focuses on, let's take a look at all the data in our organization and let's put a filter of race, ethnicity, and language. Let's put a filter of sexual identity and gender, sexual orientation and gender identity. Let's put that lens over all of the data we collect around things around hypertension and diabetes, and let's put cancer screening. Let's put those lens over that data that we collect, and where we see disparities, then let's put mitigation plans in place with our family practitioners and our cardiologists and people who are in our endocrinology departments and so forth. And what are we going to do to mitigate that so that we eliminate those health disparities and create health equity for our patients? So that's the work that we do at Swedish out of the Office of Health Equity and Diversity and Inclusion.
That is wonderful. What a good summary. I don't think, even in our conversations leading up to this, I don't think I've just really fully appreciated the large amount of work that is. What important work. Okay, I will stop talking now. I would like to open the floor to questions from our attendees today. So if you'd like, I think we have a small group. If you want to raise your hand, I can see those and we can track it that way. Malia, welcome. I hope your audio is working.
It is. Thank you
Great.
so much. I just want to say I so appreciate the facilitation of this really this community discussion right now, and I'm really trying to learn as much as I can, given the position that I'm currently in with my organization. So my name is Malia Dalio. I serve under our External Affairs and Guest Services team for Seattle Children's, and I am also the chair for the Pacifica Inclusion Network, and I'm serving on our Health Equity, Diversity, and Inclusion Council, as well as our Health Equity, Diversity, and Inclusion Communications and Community Engagement Committee. As I'm sure nobody in this space is new to the challenges that we have recently been going through within my organization following the departure of Dr. Ben Danielson, who is incredibly well respected and loved and still very much appreciated by our staff that remain at Children's, who are trying to impact a culture change from within. That is no small undertaking, given that all of us who work within healthcare organizations are battling systemic racism, not just within kind of the construct of business and as you know, this corporate business model that we all operate under, but also the added layer of systemic racism within healthcare in general. And so my question really is in terms of how has, from your perspective, Mardia, how have you been able to address some of the obstacles in sort of unpacking those layers from within? There is, especially here in the Pacific Northwest, this conflict-averse culture that really is very pervasive. And I think we have this impression that we are more progressive than other areas of the United States. But I have found that pretense is also its own form. It creates covert racism.
Yes.
And that's a unique challenge that I'm running up against right now.
You know, Malia, I could not have articulated that better in terms of the, you know, what I see in the Pacific Northwest versus other places that I've lived. I'm from Ohio, and I've lived in different places in the US and even abroad. And you're absolutely right. The Pacific Northwest is particularly challenging because this area purports that it is very progressive and aware of things around institutional racism, structural racism, and the challenges that people of color face in every aspect of life around you know, these huge challenges. We protest everything here, as far as I can see. You know, I've never been in a city where every shop window has Black Lives Matter and has a pride flag and so forth. So when I first moved here, I was like, oh, this work is going to be easy. And then, you know, I'd walk into conversations and I'd call the thing, and you know, everybody'd be like, oh my God, she actually said, you know, the R word, racism. And I'd be like, yeah, you have Black Lives Matter in your window, and you're walking around with a Black Lives Matter pin on your shirt. What did you think that meant? And so, you know, so I'm one who doesn't shy away from calling the thing a thing. And so just that in and of itself is helping people to call things as they are. That said, it does make people very uncomfortable. And so part of the culture change and what we're doing within Swedish is to have those courageous conversations and to actually point out to people that thing that we say doesn't happen in our organization. Let me give you an example of it. So one of the things that's critical to the work that we do is data collection, because the data is hard to refute. For example, when we talk about health disparity, and I'll use a particular department, when what we'll experience is you know, the voice of the patient that says, I, as a person of color, had this negative experience when I came to your health system. And we will hear that from one patient or another patient and so forth and so on. And what everyone tends to have a tendency, and I've seen this not even necessarily as Swedish, but in general, what we'll tend to do is we'll play whack-a-mole, and we'll go after the issue and we'll resolve it and so forth and so on. And here at Swedish, one of the things our CEO, Guy Hudson, is adamantly focused on rooting out the cause of systemic racism and addressing systemic racism and how it shows up in our organization. So he's very clear in his message to the staff, to the executive leadership team, and all the way down to our frontline caregivers about what is and is not accepted behavior in our organization. And so we deal with that from a communications perspective, from an expectation setting perspective, from a corrective counseling perspective. We deal with that. What we also deal with is, let's get data out in front of people that says, we have had X number of people in a particular department that have raised this concern, and it's centered in this particular area. So we pull in the leader and we pull in the staff and we say, now, whatever else may be going on in the organization or in this department that is good, here is what's not working so well. And here's the evidence. Here is the time, the date, the patient, the XYZ of when this happened. And so here's what we need to do to put in place the mitigation plan so this does not happen again. And by constantly putting that data out in front of people, there isn't a way that people can kind of skirt that and shy away from it and try to retreat from it and not confront the thing that is happening in the organization. And so by constantly putting that in front of people, there's no way to shy away from it, and people can't deny that what's happening actually is happening. And so when we start putting those mitigation plans in place, those who are serious about doing this work will come along and start to put the action in place. Those who are not, who are now anomalies, because you're going against our mission, you're going against our values, are finding themselves self-selecting out of our organization because that behavior is no longer tolerated.
Thank you so much for that. That was going to be my next comment, was that at least for that interim period before you have those escalation processes and sort of that reinforcement in place, that we are losing the people of color that actually care and are trying to do the work, because the system is not supporting you know, those stories and their voices right now. Thank you.
You're welcome. We track it. We absolutely, so our office has people on our team that and not only our office, but patient safety actually tracks those incidents. And then we review them on a monthly basis. And then we go through, and here's the thing, we've built capacity in our organization with compliance, with risk, with patient safety, where people recognize, hey, something happened, and I believe this happened as a result of bias, and they may not know exactly what it is, but their spidey senses now are attuned to, hey, wait a minute, this may be due to bias. And so they'll call in our office, and then we start doing some investigation. And if it's just something related to what a regular occurrence within patient safety, it goes through that stream and that gets resolved. If it's related to bias, it comes to our office, we do the investigation, we work with the various groups, and then it gets resolved that way. But there is a way to segregate things out, and we build capacity within our organization so that people recognize now this was due to bias and there needs to be something done about it.
Thank you. I don't want to monopolize the time. I just, you're such a wealth of information. I really appreciate your insight. Is your data made public and visible?
No, our data is not made public. It is very, very new. I started in April. My partner started in March in this role. So we have just about 5 months worth of data that we're collecting. And so we'd like to see it probably like at the half year mark, and then we're going to see it at a year mark. So we can start to see what trends look like, and then start to see whether or not things are improving. And obviously that's the goal, to see if they are improving. So yeah.
That's great. Thank you, Malia. And you are not monopolizing the conversation. These are wonderful questions that I'm sure others have too. Are there others who have questions? I can lob some in, but I also don't want to monopolize the conversation.
I guess I'll chime in. I was just curious, because it sounds like, so you're using the data to kind of find like an issue, an issue, and track that. And then when you're engaging, is it more than with the department or the area, like essentially more about like the people that seem to be directly involved in the incident, or do you bring and kind of create a broader or larger conversation about it? Kind of curious about that.
Sure, there is a broader conversation. We do work specifically with the individual, but we take a broader system-wide approach, because what we're trying to do is build, again, that culture in the organization. So for example, when compliance gets involved in it, so now is an opportunity to put policy in place. When risk gets involved, here's an opportunity to put policy in place around things like that, certainly with patient safety and so forth. And what we do is then educate, and this is part of the capacity building work too, is to educate the system around, here's what we're seeing. So for example, if we see something that may happen in cancer, for example, in our Cancer Institute, we'll pull in chief medical officer, we'll pull in compliance and risk and so forth, so that these key stakeholders are aware of what's happening, And then from a policy perspective, they recognize how this could have happened in one department and what is the likelihood that it could potentially happen in another department. And so the mitigation plan that's put in place is applicable to departments across the system, so that you mitigate it at a level that is system-wide, and so it doesn't happen and gets repeated in other departments. And so that's how we're able to, again, ensure that not only is it nipped in the bud in that particular department, but it doesn't spread to other departments.
So I guess I got to follow.
Go for it.
Absolutely.
My wife's actually a reconstructive plastic surgeon at UW, so I've had the pleasure of being along for the ride of that experience. And one of the things I know they do is an M&M conference, and I was kind of thinking about, at least and I've been going through my own educational process, joining a company, that is tackling health equity head on and learning and cultural humility. And there's something about that dialogue that sits outside of like a formal compliance type initiation. I was kind of curious about that discussion. And part of it is, I guess, the humility I relate to is watching our kids go through public education here. I mean, like my mind kind of like every 3 years is like they have a whole new like vocabulary to talk about. It might be gender, it might be like social, but like it's constantly evolving. You're like, so I think that humility is something I keyed into, and like, I guess that discussion, because you may have someone that's really progressive, but still not in one area, not in another area. And that, anyway, I just kind of was curious if as a healthcare organization, you've looked at that M&M conference, is any possible way to do it? I know it's very different in some ways, but.
Sure. I'm not familiar with the term M&M. Can you expound?
It's a mortality and morbidity, and it may be more specific to like operative or proceduralists, but it's kind of that group. So it's more that like things go wrong. Sometimes it does. Sometimes it's an issue, and it's like a peer like discussion and perspective. In theory, it's supposed to be a safe place, right? It's protected like under privacy and legal things, so that you can have a group of peers actually have an honest conversation about like what went on with the case, different perspectives and opportunities. So
absolutely. And yes, we do have, from a patient safety perspective, there is a group that certainly will review cases in that regard. And again, our Chief Health Equity Officer is involved in those conversations. And there are times when I'm pulled in those conversations as well, because we do need to understand it from that perspective to ensure that there wasn't anything untoward in that, that bias didn't influence, the outcome, patient outcome in that. And, to ensure that patient harm wasn't the result of any bias or anything from that perspective. So absolutely. We take a thorough approach in terms of looking at all patient outcomes from that perspective. And again, our staff, the folks who are trained to be able to look at all of those cases, everything from M&M, I'm going to use that new term that I just learned, to I came to your healthcare system and I didn't feel as though I belonged. Everyone who handles anything from that degree of dissatisfaction to I didn't feel as though I belong have undergone capacity building, training, learning, experience, cultural humility to understand, at least recognize something's untoward here, and I need to pull in either the health equity officer or the diversity officer to do some fact finding to truly get to the root of, I think something's not right. Let me pull some expertise in here. And then we convene and we truly look at cases in that regard.
Jeremy, I see your hand up.
Yeah, thank you. And sorry for having hopped on a few minutes late. My name is Jeremy.
That's okay.
Consultant in health and healthcare, and I run the Vaccine Equity Cooperative. And I was curious because it sounds like at Swedish, y'all have been really, really thoughtful and intentional about where this work lives in the organization and how it gets kind of instilled in real deep and meaningful ways throughout the organization. And I'm curious for your thoughts on, so often it seems when health systems in particular are thinking about making investments in health equity broadly, at least from my vantage point, it often ends up sitting in like, oh, this is something we're going to do in community benefit, or here's a role that's going to sit kind of outside the core operating, the core operating model of the organization. And, and then of course you always worry when that happens, that like when that CEO or that chief, that person who's running it leaves or goes to another place, then it kind of, there's no sustainability. It's not really built into the institution. And I'm curious for your thoughts, and I've heard some examples already in what you've shared, but your thoughts about how to make this work really core to the business and operations of running the institution, just like other aspects of the work that are important.
Sure, absolutely. And you're right. We, again, it started with our CEO, Guy Hudson, being very intentional about, I want this to be a bedrock of who Swedish is and the work that we do. And with that vision in place, what we have done has been a recognition of everyone in the organization, again, from senior leaders to our frontline team members, that what it is that we do in terms of providing healthcare to our patients in the Puget Sound region is the direct correlation is, if you're going to deliver healthcare to people, you have to deliver equitable healthcare, or else why are you doing what it is that you're doing? If healthcare is only beneficial to certain groups of people and you are not inclusive of all people, you're missing the mark. And the reality of it is, so there is a moral imperative to do this work. There's also a business imperative, there's a community imperative to do this work. And so it is core not only to our mission and our values, but it also is core to how we operate our organization. The reality is the patients that we serve are a reflection of our community and of our patient population. And so there is no way we can operate our organization and leave out a sizable amount. And then the last time I looked, and and this is one of the things that we do, we actually collect data on who is our patient population. And when you do a census report of, we operate in King County, Pierce County, we operate in Snohomish County. And when you pull the census tract data around who is our patient population, there are non-whites in our patient population. And so if you just focus on providing equitable healthcare for whites, you're leaving out a significant population of your patients. And so it doesn't behoove you, nor does it make sense to provide good healthcare for a certain portion of the population. You have to provide good healthcare for all of your patients. And so that is a bedrock of our mission and our values. And that is the proposition for one of the reasons and why we do this work. Not to mention, again, this is the right thing to do if you're going to be not only an anchor institution in this region, but also for Providence as a whole, who is an organization that is driven by its mission. This is why we do what we do, which is why you can't separate it from the operations. And so with that in mind, the work that we do every day has to be reflective of everyone that comes through our door, regardless of who they are, whether they are a BIPOC, whether they are part of the majority population. So because it's embedded in there, it naturally flows into everything from our suppliers, who we do business with, who do we engage in when we do community-based work. It looks at how are we treating patients who are indigenous to America. It looks at African Americans. It looks at the LGBTQIA+ population, because that is the composition of our patient population. We cannot run our hospital system and deliberately leave out a portion of our patient population. That doesn't work. So Jeremy, to your question, that's why it's embedded in our organization.
Thank you. Amy, I see you have your hand up as well.
Yes, and my question sort of dovetails on this discussion around data collection. Right now, we're trying to address disparities within the populations within Premera, and all the health plans are having to actually do this. One of the things we're bumping up against is we want to do the right thing for our populations, but we have very little available REL data from our patients. And so we are having to rely a lot on census data and, inferred sources, which may or may not actually reflect our population. Our populations may be slightly different. So I was curious, I would imagine the Providence system is better set up to be able to collect patient REL data just because they're right there. But do you have any recommendations around maybe how, as a health plan, we could go communicate out to our membership why it's important to when they're asked for that information? It's not because we want to be nosy or we're going to sell it off someplace. It's not for a bad reason. We're trying to be supportive. But I have concerns when I get asked a bunch of questions about my personal background.
Right.
And so I always feel better when I know what is the purpose, where is it going to go. But I'm wondering if there's a good way to be communicating that we're not doing that now.
Sure, absolutely. And Amy, your situation is a bit unique in that you work for a health plan, and which, by the way, is the health plan that Swedish uses, as a matter of fact. And so, what's interesting is we have looked at using MyChart as a way to collect real and SOGI data, and that the real and SOGI data is critical because that's one of the ways that we truly dig into patient data to understand whether or not health disparities exist. But we have looked at how do we place that information in MyChart, because at that point it is to the patient's, it's within the patient's control whether or not they are going to input their data. In the same way that you ask for name, address, and so forth, it's within the patient control. And so it's a matter of scripting. It's a matter of, and I know this for a fact because we just had a meeting on Monday with our LGBTQIA+ program, where we had a conversation about how do we ramp up our efforts to collect SOGI data from our patients that frequent our family medicine clinic, and particularly those in the LGBTQIA+ community. How do we make them feel safe enough to divulge the information that we need? A lot of it is around scripting. And so whether you're trying to do the data collection online, can we put some scripting in MyChart to explain to people why it is that we need that information? We provide scripting because we do see people in person. So our medical assistants, our physicians are well-versed in explaining the value of patients providing that information. Folks at the front desk, again, physicians, care providers, APCs. And so it's getting everybody to sing from the same sheet of music in terms of, here is the value of collecting real and SOGI data. And if you are able to clearly articulate that to the patient in a succinct manner, patients people are interested in their health. We live in a consumer-driven market that does not necessarily preclude healthcare, and people are interested in sharing that information if it's going to lead to better health outcomes from them. But what we do is we provide scripting and talk to people about this and give them this information, put it online. And that way people are very clear about why it is that you need this data so that they can help drive decisions in their own healthcare and their own health outcomes. And that's what we have found have been successful. So we literally have somebody on our staff in our LGBTQIA+ program who goes around to the different departments and will train our teams on how to be comfortable in asking for real and SOGI data, because believe it or not, a lot of people, to the point somebody made earlier about Pacific Northwest folks being confrontation adverse, people are like, oh, I don't know that I want to ask somebody about their real and SOGI data. You must, because it helps, it's for the health of our patient. And so again, if you give people the script and you explain to them why you need this data, they're more likely to respond and give you the information that you need.
Great, thank you.
You're welcome.
Thank you, Amy. Gail.
Yeah, and so to kind of build onto that whole patient perspective of things, I was wondering at your organization, giving those surveys, did the clinicians feel overburdened having to try to collect that data in addition to the work that they need to do to see the patients?
No, not really, because it's all part of registration.
Okay.
And yeah, it's when you register somebody and you sign somebody in, it's just a matter of let's collect this information as well too. So it's not anything additional included in part of the regular steps that you already have in place.
So then do you have like social workers review that information for interventions that might be needed or something to support the patient, or?
Yes, in the event that a case manager or a social worker needs that information, it is available in Epic. They can pull the patient information up and then you can see a complete profile of that patient. And as that information is relevant, you now have the tools, so to speak, that you need in order to provide the appropriate intervention. Yes.
So one thing that MITRE is doing is we convene the Codex HL7 Accelerator. And so they're working on data standardizations for cancer. And M-code is our minimum common oncology data elements. And what we're trying to do is what I'm trying to do is look at the determinant data and those patients that have cancer and how, we know that the trial participation is not diverse, right?
Correct.
So how you kind of combine, and I saw that you also offer clinical trials. So are you all doing anything to try to combine that data together?
Yes, we are. Your Gail question is serendipitous because I'm smiling because we actually are working on a project right now to diversify who participates in clinical trial, particularly around cancer. And we're looking at, in particular, breast cancer, and we're looking at colon cancer, colorectal cancer. And so what we have done just that, is taken a look at, we know based on our data who is participating in the clinical trials, and there is not enough diverse representation in those trials. So what we've done is, this is where your community health folks come into play in terms of with whom do they have relationships that represent diverse communities. For example, we know that African-American men experience colorectal cancer at a higher rate than the majority population, and then pretty much any other, even BIPOC communities, them and the Latinx population. Same thing for breast cancer. African-American women have a higher mortality rate because cancer is detected so late with that population. And again, that's data that we know from places like IHI and so forth. And so what we've done is we've worked with our community health folks with their partnerships in the community, and it can be organizations. I'll give you an example. YWCA is a community partner of ours. And so we will run the mobile mammography van out in front of the YWCA down here on 5th and Seneca, and put the van out there. We also know that Latinx women also experience a higher mortality for breast cancer. And so we're working with the organization name escapes me at the moment, but same thing. We run mobile mammography van clinics to ensure that we have higher participation rates of those two populations so that we can increase the diversity of those who are participating, not only in the screenings, but in the clinical trials, because we have relationships with those groups of the YWCA and the group that represents Latinx women. So they will come to us for screening. And so the next step is, let's talk to you about participating in these clinical trials. And because we have the relationship and we have trust with them, when we ask them to participate in the next iteration, which is the cancer screening, there's trust already built. And so we can see that there's increased participation in these types of trials and so forth. And so that's how we were able to expand our outreach.
Thank you, Gail. Melina.
Hi, I want to thank you for your work. And so far, this is very interesting to me. I'm just wondering where and how, I know your department is new. You said just since March, I think.
Yes.
So how was the department formed? Was that from Swedish, from Providence, from your CEO? What was that process like?
That was myself and my chief health equity officer. I remember when it was the two of us, and they would be like the Office of Health Equity and Diversity and Inclusion. She and I would look at each other. You mean us? Like the two. And it would be Dr. Anyaku and I, and we'd be like, okay, so which one of us is going? So it literally was the two of us, and which is why I can remember this summer. My goodness. So we this is a grassroots from the ground up organization. And what's interesting, I've done this work before, as has Dr. Anyaku. I've been a chief diversity officer in a health system back in Ohio. Dr. Anyaku has done health equity work back in New Jersey. She worked for the governor. I think Cory Booker was the governor, or not governor, but somebody in New Jersey, and she worked with him. She's done this in Oklahoma. I've done this in Cincinnati. I've done this in a variety of places. So we know what the blueprint for standing up an office like this should look like. And then, of course, we're also guided by organizations like the Institute for Healthcare Improvement. We're guided by organizations like the Race Equity Institute. We're guided by best practices from different organizations across the country. And so we were able to pull a department together, and we know what are some of the different aspects that an office like this needs to have in place. For example, for patient advocacy and voice of the customer, you need a voice of the patient. You need an ombuds person to be able to hear what the customer is saying and be able to get in the middle of patient concerns and so forth, and hear partially, impartially what the concerns are. We know that when you're doing this work internally to build culture, you need to put in things like employee resource groups and so forth. We know that diversity recruitment really helps to diversify your workplace so that it more reflects your patient population. We know that real and SOGI data is critical. That is the critical lens by which you look at all of your health data so that you can tell whether or not there are disparities. We know that you have to work with community health based organizations in order to reach your patient populations and so forth. So this has been work that we've been able to put in place over the last 7-8 months or so, and continue to build it. And then we follow the model, so to speak.
That's great. What a good question, Melina. So in the absence of anyone else raising their hand, I have a question. So
Sure.
I kind of want to dial back a little bit and kind of take a bigger picture look. So you have worked in healthcare, but you've also worked in a number of other industries. I mean, kind of across the board. So I'm curious if your experience and what about the experience in healthcare and kind of the healthcare industry maybe is unique as compared to some of those other industries.
Sure. And again, I have worked in, oh my goodness, supply chain. I've worked in IT telecommunications. I've worked in consumer products goods. My goodness, let's see, retail, entertainment, non-for-profit, and
You've done everything.
I know, right? I was telling Laura before all of you got on the call. I don't know that I necessarily planned this out, but then when I look back in hindsight, I'm like, what in the world were you doing? So, but what's interesting is, I will say this: people are people. People come into spaces, be it work, into organizations, and so forth, with the expectation that, and especially today, and into what we have evolved into, both as a society and a country, people's expectations are, I want to be treated with dignity and respect. And even more so today, I want to be able to show up in a space and be myself and be my whole self. And I want to be accepted for who I am. And I don't want to have to make excuses for who I am. And I deserve to occupy the space that I'm in. No questions asked. And from one industry to another, across the world, that is the expectation that people have nowadays. And so regardless of the organization that you're in, that is the expectation that people have, and successful organizations quickly recognize that and respond accordingly. And so from a DEI perspective, organizations who recognize that, understand that, and respond to that are the ones that are leading organizations. Because if you look at things like the Great Resignation right now, people are like, you know what, and especially with the advent of COVID, where no one knew who was going to die next. People just, you woke up one morning and it was like so-and-so died, and you woke up and so-and-so has COVID, and entire families and things were decimated. And so the values of Americans and people across the world have changed, because it's like, you know what, this life, this world is not what it used to be. Some of the things that we valued, we found out doesn't matter and is not of value anymore. But what's important are people and people's lives and their experiences and so forth. And so when it comes to jobs and organizations and so forth, that is now not everybody's top priority anymore. And subsequently, when people walk into these spaces, into these organizations and these companies and so forth, your work and your job has a certain value and a certain place in the hierarchy of priorities. And if people feel as though they come into a space, they're not respected, they're not treated with dignity, that from a life balance perspective, that they're not valued, they're going to walk away. And so when we look at the composition of who is in our organizations anymore, what's important to people matters. And when I show up in a space, I need to feel as though I belong in that space, because if I'm going to give my time, talent, and treasure and attention to anything, I need to feel as though I belong. And if people don't feel that way, and if we don't put policies in place, and if we don't create a culture like that, people are going to walk away, because that is just not their, jobs and work and all that. That is not the be all to end all anymore. And so it behooves us to welcome people to our organization and create cultures of inclusion, to create places where people recognize that I bring a certain amount of value to this organization, and that needs to be accepted, that needs to be respected, and that needs to be cultivated. And so our organization understands that, and little by little, it is something that is treasured in our organization.
That's wonderful. Okay, let's see. We've got a question in the chat. My mouse is going crazy. So do we see more awareness from Asian Americans to be more proactive in this pandemic in health equity? Thank you, Ting Ting, for lobbing that in.
That is a great question. Absolutely. One of the things, and so let me talk about this, and I want to dispel this just really quickly. Ting Ting, thank you. That is a great question. What you know, there is this myth about the model minority with regard to Asian Americans. That is, oh my God, that is such a myth, and we need to dispel that quickly, and get rid of it. Asian Americans in our organization play a critical role, because I will tell you, Asian Americans make up about, I want to say, about 18% or so of our workforce, and play critical roles in our organization around, in terms of leadership, in terms of, holding manager level position, supervisory level positions, and so forth. And from a health equity perspective, in terms of leading that work, absolutely. And what that looks like is our Asian American population have a significant voice in our organization. And because they have that voice, they use their voice, because we don't fall into that model minority myth, where there is that adage that, well, some Asians are not going to say anything, and if something's going on in our organization. So all of those myths and those stereotypes that we have about different groups of people, we don't categorize people. There are individuals in our organization who have a voice. They use their voice, their voices are valued. And so as we have things that come up around different populations of people, we go to the experts within our organization and we ask for their voice, and we cultivate their voice in terms of, how do we reach out to a specific population? How do we pull in a specific population to get information to be able to treat and work with a particular population? So as it relates to Asian Americans, Ting Ting, that is a population, an employee population that has a significant voice in our organization. And I will tell you, what was interesting is our Chief Communications Officer is Mona Locke, is Asian, and Mona will use her voice very clearly to articulate to us what's happening in that particular population, is something that we need to promote to ensure that Asian Americans in particular are represented, and that their voices are heard as we look at health equity and we bring programs to that particular population.
Thank you. Any other questions? I can continue to ask my own, but I want to open the floor. Y'all are quiet.
Yeah, so there were some people put what they wish to learn more about, and perhaps maybe we can talk about some of them. Somebody put on here just some best practices. Some people talked about let's talk more about concrete ways to pursue health equity, strategies to ignite change. Does anybody have any questions around those? And perhaps we can talk about them.
I have just kind of one question that is maybe not super specific to okay, I'm just gonna ask the question. So I'm kind of curious, one of the things we talked about when we were kind of ideating this roundtable and then the previous Under the Boughs conversation is we really want to equip people with kind of some actionable things that they can do in their daily work to address health equity. And so I'm curious if you have any thoughts, or if anyone does. I mean, all of you have a different role that you play within the healthcare system of, next week, what can we do to kind of move the needle forward with health equity?
Sure. one of the biggest things that all of us can do is be an active bystander. And what I will say to that, earlier this week, one of the things that we did some implicit unconscious bias simulations in one of our departments, so that we could, in essence, simulate what does bias look like in a care situation. And so we pulled together some of our care team members, and we, in essence, had an actor as a patient, and we pulled the care team together. And it was, what was interesting, it was an African American patient, and we depicted what does pain management looks like for African Americans, which we know is problematic. That is an area of concern with regard to how pain medication is administered to African Americans, actually to BIPOCs in general, versus majority patients. And so we did a simulation for our care team around what that looks like. And I will tell you, that was for me one of the most profound experiences. And I was one of the ones who was conducting the simulation. And I was like, OMG, it was so profound. Because to see it in action, you're like, are you serious? And it's like, yeah, this stuff really happens. And so what was interesting is, during the simulation, it played out exactly as we all know this plays out. And what the biggest learning from that was, people were like, this looks familiar. And so then we asked, what would you do when you see this happen again? And then we started to get into tools around, first of all, disrupting bias. But then what can you do? Because people are saying, this looks familiar and I've seen this happen. And so we were asking, so what would you do in a situation like this? And how are you going to behave differently when this happens? And so we got into, here's a tool for you in terms of being a bystander and an active bystander. And it calls on being bold, and it calls on being brave, and it calls on, if you are a healthcare practitioner, and at the heart of the matter is a patient, and in all of us, there is something that triggers when you know something is not right. And I go back to, the late Congressman John Lewis, who said, if you see something, say something, do something. We all know when something is untoward, it's like a scratch in a vinyl record. I'm showing my age at this point. Something is not right. Say something, do something. And that is so difficult, because we're like, oh my God, this person's gonna think that I'm calling them a racist, or, I have to go to lunch with this person and they're gonna, they're probably not gonna want to go to lunch with me, or, the myriad of reasons that we come up with about why we're not going to say something or do something. And you have to think about your patient. This is a person who is in the hospital. Nobody comes to the hospital to hang out. That's not what we do. We come to the hospital because we're vulnerable and we need care. The biggest thing that I can say to you is, say something, do something. And when you do that, it catches on. The next person's like, you know what? I was kind of feeling the same thing too. I noticed the same thing too. And I was going to say something. But now that you have, and the minute the one person says something, the other person says something, and then the next person says something. And all of a sudden, the person who was the one who was the instigator became the outlier. And then the rest of the team was like, well, you know what? I don't think that's right. And I don't think you should be doing that. And did you hear what the patient said about their pain? And did you recognize this? These are the things that I noticed. So the biggest advice and the biggest takeaway that I would say to you as a healthcare practitioner, or if you're in this space and you're looking at, even from a policy perspective, if you see something that's untoward, say something, do something.
What wonderful advice. Thank you for that. Malia, I see your hand is up. Please join us again.
Hi, thank you. This is so good. Thank you for everything you just said. I have been responding via emojis the entire time you have been talking because I am just so am appreciative of us even holding space to have these conversations. We have to normalize these conversations in all of our spaces, right? The active bystander is such a big one for me right now because what I have seen as we are all reacclimating to normalizing these discussions in our professional spaces and specifically in healthcare has been there's been a white silence that I have observed from my own colleagues who are well-intended and informed themselves, but still, I think, don't quite know which foot to put forward at this junction. They are trying to actively listen and receive a lot of the feedback. And so I think some of them interpret that as because we're giving them somewhat conflicting directives while we're saying, don't lean on your BIPOC colleagues to do the work for you. But at the same time, we're saying you need to bring us in these spaces and we need to be able to have a say in these conversations and inform directions, right? So they're kind of like, okay, which one is it? You know, am I not supposed to reach out to you? Or am I supposed to reach out to you? And am I supposed to let you lead, or is that burdening you, right? So I'm sensitive to that. But what I have seen with escalations is there's been so many different escalations that are now coming to me from all different directions, right? Because what this work is doing is it is deconstructing the silos within our organization and the silos, the cones of silence as well. And so people now feel empowered to reach out to people that maybe it isn't part of their direct escalation roll up, right? So they're just pulling in anybody that they see as an ally, anybody that they see will listen, anybody that they see can help and kind of raise the alarm to things. My question for you is, what has been, so I've worked in healthcare for 20 years and majority of that time has been spent in adult medicine. There's this whole other layer with the pediatric, field that I'm now in, because you have to add the parents, right, and the families to that component. It's a package deal with the patient. But what has been, from your experience in all of the organizations where you've helped to kind of implement these changes, one of the biggest mistakes that you've seen organizations make, either via policy or how they've responded or not responded to the change effort?
Sure, absolutely. One of the biggest mistakes that I have seen has been when organizations put out statements and put out directives and put out expectations and so forth, and we hold out sacred cows. And we said, well, it doesn't apply to so-and-so. And so violates whatever the tenets are that we're trying to let permeate through our organization. And we say, this is a value within our organization. This is something that is important to us. But somebody either high in the organization, somebody valued in the organization, somebody who's a long-term person in the organization who is highly respected and so forth, violates the very thing that we have publicly said in the organization is unacceptable, and we make an exception for them. That undermines everything that you're trying to do within your organization, because people see that, they're like, oh, they're not serious. This only applies to the little people. People say things like that. And I will tell you, it's interesting because when I interviewed with Dr. Hudson, I was like, okay, so now I'm going to move across the country from Ohio to the Pacific Northwest. It's 2,190 miles. and I am coming to Seattle. And let me tell you what this is going to look like. They're going to be mad at me. They're going to come and tell on you about, oh, Marty's in there doing this, and she's disruptive, and this, and this, and this. You do not have any sacred cows, okay? If so-and-so misbehaves, if they do anything that's contrary to what this work that we're trying to do, I need you to be bold, and I need you to stand up for this work. And he and I have an agreement, and he has held steady. And I will tell you, I speak very highly of my CEO because he is true blue to this work. He supports this work 100%. He has no sacred cows. And if somebody misbehaves and they are their actions and behaviors are incongruent to this work that we're doing, he does not protect people and say, oh, you know, they bring this value or they've been here this long or whatever. He's like, nope, they cannot be a part of our organization because they are undermining this work that we're trying to do. And we are here to take care of our patients. And if somebody's behaviors and actions are contrary to that, they cannot be in this organization because we need to hold firm to what it is that we're trying to do. And I've seen him do it. So that is the biggest mistake that companies make, is they hold out and will not take action against sacred cows or, people who wield a lot of influence and so forth.
Thank you for that. Could not agree more.
Yeah, same. I've seen the same, having been in healthcare for a little while as well. So with our few minutes remaining, I'm gonna go ahead and launch this poll. I know we lost quite a few to other meetings, but I'm gonna launch it really quick. So let's do that. And then while this is going, Marty, I'd like to just invite you for any, closing remarks or any final things you'd like to share with our attendees today.
Sure. So what I will say to you, this work is hard. I don't know that I'm saying anything to anybody that all of you don't know. This work is hard. This work takes time. Ultimately, what we're trying to do is change behavior. And whenever we're trying to change behavior and whenever we're trying to influence how people think about things, it's hard work, because the reality is a lot of people's beliefs and mindsets are steeped in, how they were raised. It's steeped in their community, is steeped in, your culture, your background, again, your lived experiences and so forth. And so when we come to people in this space, what we're doing is challenging everything that they know, everything that is familiar to them, and we're introducing new concepts to them, and we're asking them to consider something different. And that's hard. That's hard for a lot of people because it requires change, and we all know how difficult change is for a lot of people. However, that said, those of us who do this work must recognize that the reality is our society has changed and is going to continue to change. And so we have to be steadfast in this work. And what keeps me motivated anyway is thinking about the fact that at the heart of all of this are people, and people who are vulnerable, and vulnerable, not necessarily in the sense of socioeconomic status and dealing with the social determinants of health and things of that nature, but particularly in healthcare. I referenced earlier that people don't come to the hospital or go to the doctors because they want to hang out. When you want to hang out, you go to a restaurant or you go to an amusement park or whatever. When you go to the hospital, you're in a vulnerable state. You're not well, and you need an advocate, and you need somebody to stand up for you. You need somebody to look out for your well-being. And as you can imagine, if you go into a healthcare setting and you're treated less than, and you're not giving the best care simply for something that is completely out of your control, whether it's due to your socioeconomic status, or whether it's due to your marital status, or whether it's due to your sexual orientation or gender identity, that's not fair and that's not right. And we as a society must do better in taking care of those who are vulnerable. And then certainly when we get to people whose life experiences, for whatever reason, whether they're unhoused or whether they are single parents who are struggling with things around transportation or food insecurity and so forth, that makes the urgency of caring for people even more critical. And so to keep that in mind as we do this hard work, when some days you're like, are you kidding me? Like, I can't believe that, we're having this conversation and people don't understand it. So this work is hard, yet it's critical to keep in mind that one person that you help today, and the policies that you write, and the dismantling of these systemic and institutional things that would inhibit people from getting the level of care that they need, is the reason why we do this work. And so continue to plug at it, continue to push, continue to find your voice, and to not be afraid to stand up. And even if it comes to it costs you personally, there is a higher purpose in doing this work. And so that's what I would say to each and every one of you. And that's why we do this work that we do.
Thank you so much, and for that encouragement. And thanks to all of you for attending this afternoon and sticking it out. I know that this week can be hectic for a lot of people leading into the holiday. So thanks to everyone who was able to join, and for those of you who are watching the recording. So I will send around a recap email and include a link to this recording so that you all have access to it. It will also live on our website, so you'll be able to find it there as well. And with that, I hope you all stay safe and healthy and enjoy the upcoming weekend.
Hey, thanks everyone.
Thanks a lot. Bye, everyone.
Bye.
Take care. Bye-bye.
Bye.